Welcome to this lecture. We are going to discuss ultrasound features of common adnexal cysts, as about 90% of adnexal cysts can be adequately characterized with ultrasound alone. Simple ovarian cysts are commonly seen on ultrasound. They are anechoic structures having thin wall with increased through transmission. No solid component or septation. There should be no internal vascularity at color Doppler examination. They are very common, particularly in premenopausal patients. They are usually functional follicular cysts, and almost always benign. Cystadenoma may appear similar to simple ovarian cyst. However, they tend to be larger. Cystadenoma don't regress like the follicular cysts, and they are more common in older patients. Malignant degeneration is very uncommon and likely takes a relatively long time. How do we manage these ovarian cysts? In premenopausal women, simple ovarian cysts less than 3 cm in size are considered a normal physiologic finding. Cysts between 3 to 5 cm in size are highly likely to be benign. You just describe in the imaging report and don't recommend follow-up. Cysts between 5 to 7 cm in size should be described in the imaging report with a statement that they are almost certainly benign. Yearly follow-up with ultrasound is recommended. If the cyst is greater than 7 cm in size, further evaluation by MRI or surgery is recommended. Because when it gets so large, it can be hard to completely skin the cyst wall, and you may miss a tumor nodule in the cyst wall. There is also a risk of torsion and rupture. For postmenopausal patients, if the cyst is less than 1 cm in size, it is clinically inconsequential. No follow-up is needed. If the cyst size is between 1 to 7 cm, they are likely benign. But recommend to obtain yearly follow-up until the cyst is stable or decrease in size is documented. Some people use 3 cm in size before following. Again, like premenopausal patients, cysts greater than 7 cm in size require further evaluation by MRI or surgery. Hemorrhagic ovarian cysts are generally due to hemorrhage within a corpus luteum or other functional cyst. Hemorrhage usually occurs during ovulation, secondary to rupture of germinal epithelium. These cysts are seen in premenopausal women or sometimes in early postmenopausal women due to occasional ovulation. The classic history of hemorrhage into an ovarian cyst is the abrupt onset of pelvic or lower abdominal pain, which can wake the woman from her sleep. Their ultrasound appearances are well described in the literature and vary depending on whether it is an acute or a resolving process. On ultrasound, hemorrhagic ovarian cysts have thin regular wall, with increased through transmission. No internal vascularity on color Doppler examination. The internal echoes are variable over the time, because the blood is changing and resolving, and ultimately the cysts will resolve. In acute stage, hemorrhagic ovarian cyst contains clotted blood, which at ultrasound manifests as intensely echogenic, avascular, homogeneous or heterogeneous, non-shadowing material. At this stage, hemorrhagic cyst may simulate a solid mass. In subacute stage, the clot may retract, remain avascular, and pull away from the cyst wall. Its surface is often undulating, and it has a characteristic concave or straight contour. Since the clot is relatively soft and gelatinous, jelly-like movement will occur when pressure is applied with the transducer. In contrast, a neoplastic mural nodule is vascular and has a convex surface contour. And because it is firm, it will not move when pressure is applied with the transducer. A common feature of a resolving hemorrhagic cyst is the presence of ultrasound findings that are consistent with fibrin strands. Multiple descriptive adjectives can be used to report the appearance of this avascular material. Acceptable terms include cobweb, reticular, lace-like, fishnet, and spongy. This refers to irregular fine lines that typically do not completely traverse the cyst. In contrast, the word septation should be avoided, since it implies thicker, often vascularized, linear echoes that typically traverse the entire cyst and are associated with a neoplasm. In premenopausal women, cysts less than 3 cm in size, whether you describe or not in the imaging report, it do not need follow-up. Cysts between 3 and 5 cm in size should be described in the imaging report. Follow-up is not needed. Cysts greater than 5 cm in size should be described in the imaging report. Short interval follow-up with ultrasound, 6 to 12 weeks, is recommended to ensure resolution or change in size. Hemorrhagic cyst may be seen in early menopausal women as ovulation still occurs. So, any such hemorrhagic cyst should be described in the imaging report. Short interval follow-up, 6 to 12 weeks, with ultrasound is recommended to ensure resolution. Since women in late menopause do not ovulate, they should never have a hemorrhagic cyst. So, any cyst with such an appearance should be considered neoplastic, and surgical evaluation should be considered. Endometrioma is known as chocolate cyst or endometriotic cyst. It is formed by extrauterine functional endometrial tissue involving the ovary. It forms when ectopic endometrial glands and stroma in the ovary bleed. It occurs in women of reproductive age. Repeated bleeding and resorption every month in response to hormonal stimulation produces thick, concentrated, and degraded blood products. It has a fibrous capsule and occurs bilateral in up to 50% of patients. Usual presentation is with dysmenorrhea and infertility. Endometrioma typically appears as complex cyst. It is usually unilocular, but can be multilocular. It shows diffuse, homogeneous low-level internal echoes, giving a ground glass appearance. It usually have thin wall, and may have a thick, fibrous wall. There may be tiny echogenic foci, and small solid areas along the cyst wall. There should be no internal vascularity at color Doppler ultrasound. A small percentage of endometriomas have less typical ultrasound features, such as anechoic fluid, a fluid-fluid level, heterogeneity, or calcification. Endometriomas may occasionally simulate a solid mass, especially when they are chronic. About 1% of endometriomas are believed to undergo malignant transformation, usually endometrioid or clear cell carcinoma. This is more likely in women older than 45 years of age and in endometriomas larger than 9 cm. Development of a significant solid component with flow on Doppler should raise concern for malignancy. In premenopausal women, when ultrasound features are atypical for endometrioma, an initial short interval follow-up with ultrasound 6 to 12 weeks is helpful to ensure that it is not hemorrhagic cyst. Cystic masses with classic features of an endometrioma should be followed with ultrasound if they are not removed surgically. In general, follow-up should be at least yearly to ensure that the cyst is not progressively enlarging and not changing in internal architecture. Ovarian dermoid cyst, often referred to as mature cystic teratoma. It is a benign germ cell tumor of the ovary, which occurs during reproductive years. It is the most common benign ovarian tumor in women less than 45 years old. It is composed of well-differentiated derivatives of all three germ layers. Fat is present in about 2/3 of cases. It is bilateral in 20% of cases. It is often discovered accidentally and may predispose to torsion. On ultrasound, mature cystic teratoma is a cystic adnexal mass, containing a highly echogenic mural nodule with distal acoustic shadowing, known as Rokitansky nodule, or dermoid plug. This echogenic focus consists of adipose tissue, hair, and calcium, which cause posterior acoustic shadowing. Very echogenic focus casting a sharp acoustic shadow is due to the presence of bone or teeth. Other common appearance is diffusely or partially echogenic mass, with distal acoustic shadowing. Shadowing may be so marked that only the superficial part of the cyst is seen. This appearance is called the tip of iceberg sign. Other common appearance is dermoid mesh, which is multiple thin echogenic lines and dots, caused by hair in the cyst cavity. Intracystic floating echogenic balls, which move with change in the patient's position, is uncommon, but characteristic for dermoid cyst. Other uncommon appearance is fluid level, with more echogenic fluid layered on the top of serous fluid. This is opposite to the hemorrhagic cyst, where echogenic blood products are layered at the bottom. There should be no internal vascularity on color Doppler examination. Take-home message. Highly reflective area with distal shadowing in a cystic mass is highly suggestive of a dermoid, or mature cystic teratoma. Blood clot in hemorrhagic cyst and solid elements in a complex ovarian cyst can appear echogenic, but is less echogenic than the fatty component of a dermoid cyst. And don't cause shadowing. Malignant transformation is reported in about 2% of dermoids, is almost exclusively to squamous cell carcinoma. It tends to occur in women older than 50 years and in tumors larger than 10 centimeters. The latency period is about 15 to 20 years before they undergo malignant transformation. Ultrasound features suggestive of malignancy are solid areas with flow on Doppler, branching structures isoechoic to the wall, and invasion into adjacent organs. Masses with features classic for a dermoid usually do not need other imaging modalities to establish the diagnosis, but should be followed with ultrasound at initial interval between 6 to 12 months, regardless of age, if they are not removed. The purpose of follow-up is to ensure that the lesion is not changing in size or internal architecture. Thank you very much for your attention.